Coming up on the FSR Sarc Fighter Podcast, a leading researcher who's looking for the cause of sarcoidosis.
You know, there's a lot we don't know about sarcoidosis, but the one thing we do know is that it is a disease of the immune system.
Dr. Courtney Montgomery believes our genes play a key role in whether we get sarcoidosis.
When you compare like siblings, for example, to just the general population. So we know genes are involved. So that's a big part of what we do. We're looking at what are those genes that sort of underlie why the immune system is behaving the way it does.
This is the Sarc Fighter Podcast, living with sarcoidosis and other rare diseases. Here's your host, John Carlin.
Hello, this is episode 142 of the FSR Sarc Fighter Podcast. I'm your host, John Carlin. The date of this recording is July 5th, 2025. And I hope you attended and enjoyed the FSR Summit. It was just this past weekend. I very much enjoyed hosting a discussion on Sunday, late morning, early afternoon, depending upon what time zone you are in, maybe. The discussion was on exercise and sarcoidosis. Takeaway is that it really helps you cope with the illness, exercise does, and that exercise helps our body fight the effects of sarcoidosis. And I teamed up with Royce Robertson, who is a cyclist and has cardiac sarcoidosis. Also on the panel were Marion Patesnick, who is a physical therapist and whose family members have battled Sarc, and Kathleen Turano, who is a dancer who had to slow way down because of what sarcoidosis has done to her. Now, Royce has been on the podcast many times, and in fact, he was the guest on the episode previous to this one, and he's once again raising money for FSR. This time he's doing a bike ride from the very top of New York State up against Canada, all the way down to Albany. And then in so doing, he will have completed the entire Empire Trail, which is about 750 miles of riding. He's done this over a series of summers. And I would like to encourage you to join me in supporting Royce with a donation. And you can do that at Cycle for Sarc. That's cycle and then the number 4, Sarc, and of course there's a link in the show notes. Meanwhile, I've been in touch with both Marion and Kathleen, the other two panel members, to line them up as guests here on the podcast. Kathleen has a very compelling story to tell. She was a very high-level dancer, and now is not. And I don't want to steal her story, but I think when you see how she just keeps on pushing through regardless of what sarcoidosis throws at her, I think you will be impressed, and I think you'll come away with that feeling of hope that I want everybody to feel as a part of listening to this podcast. I talk about it all the time, how there is hope out there. There is something on the other side of wherever you are right now. And you need to keep plugging. You need to trust your doctors or change your doctors, but know that there will be opportunities for you to continue to live a happy life. And then toward that end, Marion is so full of energy and information, and she will totally have you motivated to get up and going. She's a physical therapist, but she understands right down at the cellular level. She talked during our discussion about mitochondria in your cells and how they're the powerhouses that keep us energized and keep us going, and how critical those are to fighting against the effects of sarcoidosis on a daily basis. So anyway, Kathleen and Marion will be joining me later this year here on the FSR Sarc Fighter Podcast. Now, I am pleased to report, and I think I might have mentioned this last time, but I can say it again. The FSR Sarc Fighter Podcast now has over 100,000 downloads, and I just want to sing that from the rooftops. In fact, can I check? I don't know where we are right now. Oh, it wants me to sign back in. That's the way the apps are. Let me see if I can do this quick. I want to give you the number right now. You might be at 101,000. No, 100.6. So we're about 400 downloads away from being at 101,000. So that's just beautiful. Makes me very happy. But again, thanks to all of you who have listened, those of you who continue to listen. It really fills my heart when someone finds the show and then starts heading into the back episodes, and that you who do that feel like it's important, it's fulfilling, it's entertaining enough to spend time with this podcast. And, being in the news business all my life, I've often found that things that are important aren't always entertaining or fulfilling. I really hope that with this podcast, we get to the cream of the crop, the best stories that are out there, and the information that's out there that you want. And so I've got a couple of things here that I want to talk about. First of all, this is interesting. This is from Sarcoidosis News, written by Lila Levinson, PhD, and it's about an injector that is getting good reviews. So just reading from their news release here, most people with inflammatory conditions reported overall satisfaction, convenience, and confidence when self-administering Acthar gel through a single-dose pre-filled injector called SelfJect. That's according to a survey-based study sponsored by the therapy's developer Mallinckrodt, which is a well-known pharmaceutical name in the sarcoidosis space. The study involved 54 patients living in the U.S., 8 of whom had symptomatic sarcoidosis. The company, Mallinckrodt, designed SelfJect to make self-administered injections easier for patients, particularly those who have issues with vision or dexterity. And there is a quote here. It says, real-world perceptions are critical to capturing patient satisfaction and treatment experience with SelfJect beyond clinical trials, especially for those living with conditions that can often be challenging to manage. And that's from George Wan, PhD, Vice President of Evidence Generation and Data Sciences at Mallinckrodt. And he said also, findings from this patient survey enhance our understanding on the use of Acthar gel via SelfJect in appropriate patients. Now, in case you're wondering, Acthar gel contains a mixture of hormones and proteins released from the brain's pituitary gland that are thought to have anti-inflammatory effects via multiple mechanisms. It's approved in the U.S. for certain people with a range of chronic and acute inflammatory and autoimmune conditions, including symptomatic sarcoidosis, multiple sclerosis, lupus, and one other... I have never had to say this. Ankylosing spondylitis, Ankylossing spondylitis, Spondylitis. That is not one that's come across my desk before. But at any rate, the news release says that adults can self-administer the treatment with a syringe and a vial, into the muscle injection, but that does require some skill and some motor control. And again, a quote, patients, particularly those with chronic or acute inflammatory and autoimmune conditions who may experience dexterity or visual challenges and need access to delivery devices that they feel are easy and convenient to use, are the patients they're targeting here. And the pre-filled injector in SelfJect has a design that they say is easier for people with grip issues to hold on to. It requires fewer preparation steps, and they say they've used it to administer 40 or 80 unit dosages with just the press of the handle. And so this has got to be similar to, and I haven't seen a picture of it, but it has to be similar to what I use to inject myself. Which I have to do every couple of weeks, and it is much easier. Back when I was taking methotrexate, I was using the old-fashioned syringe and needle, and I had to, put the needle into the medicine and then slowly pull it out until I had the proper dosage. And then I had to put it in my leg and I had to press it down. And the first couple of times I ever had to do that, it was really scary. And when a doctor first told me that, yeah, we're going to have you inject yourself, it's like, I'm going to give myself a shot. I was at the time probably 59 or 60 years old. I'd never given myself a shot. And that's, you go to the doctor to get a shot. But at any rate, I take Humira, and I've used their version of this self-ject. I'm sure that there's a different name for it, but it is a lot easier than the old-fashioned syringe. And all I have to do is find a little section of fat around my belly, which is very easy, very easy to find. And I hit that thing, and it works, and I don't have to worry about it. And it looks like the research from Mallinckrodt is that folks who are using their device with this drug, Acthar gel, which I don't know a lot about, but it seems that people like it. So good news, and I thought I would pass that along. Also, FSR, which is, by the way, 25 years old this year, recently announced, this was just last month, that Mark Malazzi, MD, MPH, has been selected to receive the 2025 ATS FSR Partner Grant, which is awarded to support innovative research in sarcoidosis and advanced patient care. The FSR ATS Partner Grant is a cornerstone of both organizations' commitments, and when I say both, I'm talking about FSR and the American Thoracic Society, in fostering early career investigators, and they're providing $100,000 in funding, $50,000 a year for 2 years to support groundbreaking research projects that have the potential to significantly impact the understanding and treatment of sarcoidosis. Since 2005, this partnership has now funded over $1 million in sarcoidosis research, catalyzing further advancements in the field. And Dr. Malazzi's grant will provide the scientific community with valuable insight into the environmental causes of sarcoidosis, said Mary McGowan, President and CEO of FSR, and who has appeared on the podcast multiple times. Mary says, "We are pleased to partner with the American Thoracic Society to support dedicated investigators like Dr. Malazzi, who are committed to increasing the understanding of this complex disease." And by the way, Dr. Malazzi works at National Jewish Health, and he was selected for his project titled Association of PM 2.5 Exposure with Sarcoidosis Outcomes at Baseline and Longitudinal Follow-Up. Okay, the study will look at the possible link between air pollution and sarcoidosis. That I can understand. And so I am guessing that we look at air pollution and we look at something that we have seen over and over, and we've just kind of grazed the surface of it here on the podcast. But it's well known that first responders and people exposed to all that terrible dust when the towers fell on 9/11, the incidence of sarcoidosis from that group of people is much higher than it is in the general population. And the other thing that we've seen is people who are exposed to forest fires and the wildfire smoke. If you remember the terrible California fires from 2024, and that was one of the things that there was so much cause for alarm because the feeling was that smoke was going to trigger a lot of sarcoidosis. And so now we've got a $100,000 grant out there, and that's going to help research the link between, according to this news release, all types of air pollution and sarcoidosis. So Congrats to Dr. Malazzi for receiving the grant. Thank you to Dr. Malazzi for pursuing this line of study. And we're so happy that FSR is partnering with the American Thoracic Society to get it done. All right, I'm very excited to present our next guest. She's just wonderful. Dr. Courtney Montgomery of the Oklahoma Medical Research Foundation. And I have to tell you that she is truly cut from different cloth. Now, most of what I'm about to tell you did not come up when we were talking, but in researching her, I found a post about 7 things you don't know about her. And I'm not going to list all 7, but I picked some of the highlights. She said, I figure skated as a kid. I wore those sparkly sequined costumes and even made it to the U.S. Midwest Regional Competition, and she said it was a huge deal. And then she throws in there, but I never got to skate to cool stuff like Eye of the Tiger. It was all classical music for me. Okay, but then, number 2, over the years, I've sung in commercials, a couple of recorded albums, a spot for a hospital, and even a music video for a local rock band. So where's that talent come from? So she's a singer and an ice skater, but then and here's, of course, I like it when they play the mom card because I think that's the most important role. She says, now I just sing my 2 youngest boys to sleep every night. And she says that she and her husband grow a lot of their own food: apples, pears, plums, pecans, berries, grapes, and vegetables. She says we trade our produce with neighbors for fresh eggs. And if we just had a cow, we would be set. And then she says she's a total adrenaline junkie and loves extreme workouts like obstacle courses, bungee jumping, and parasailing. All of that. And she is one of those super smart researchers who might one day tell us all why we get sarcoidosis, because all of her work is done in the genetic field. And Dr. Montgomery is next here on the FSR Sarc Fighter Podcast.
I feel like a zombie, just feeding and stumbling.
Hi, I hope you're enjoying the Sarc Fighter Podcast. You may be wondering, what can I do to help? How can I be a part of the sarcoidosis solution? It's simple. Make a donation to KISS, Kick In to Stop Sarcoidosis. 100% of the money goes to the Foundation for Sarcoidosis Research. Look for a link in the show notes of the Sarc Fighter Podcast. Welcome back to the FSR Sarc Fighter Podcast, and joining me now is Dr. Courtney Montgomery with the Oklahoma Medical Research Foundation, and she is one of the people trying to figure out what causes sarcoidosis. Welcome, Dr. Montgomery.
Thank you. Thank you for having me.
So tell us all a little bit about your foundation there. You're not affiliated directly with any hospital, but you're doing valuable research. How do all those lines cross?
Yeah, well, thanks again for asking. So the Oklahoma Medical Research Foundation is really a unicorn. We are a non-for-profit research institution. We do have some active clinics where patients come for continuing care in the spaces of multiple sclerosis and other autoimmune diseases. We do have some Sarc patients also that come for continuing care here. But my specific research clinic is just for the purposes of research. So the sarcoidosis patients that I have the privilege of interacting with are here because they want to, be a part of helping themselves as well as helping others.
Got it. So you see patients on a regular basis, right?
We have a weekly research clinic, yes.
And what is that? What do you say when a weekly research clinic? What is that?
So patients find out about our study through various social media, or we've had the privilege of being on local news stations and so forth. And actually, patients have come from lots of them find out about us through FSR, and they notify us that they're interested in participating. We arrange a visit, and they come, and we do a blood sample, because again, they're gracious enough to let us do that and use that as part of our research program. And then I get a chance to meet with them, get a chance to talk to them about their story, talk to them about everything from their occupational history and their family history, their ancestry, all the way through their clinical journey, the signs and symptoms that they have, the organs that they have involvement with. And we just kind of talk to them about, being advocates for themselves, and just really try to give a holistic view of what sarcoidosis is, what our research is focused on, and then offer any help that we can in their journey.
Got it. Got it. So what is your research focused on? What is it you're trying to figure out?
Yeah, so, there's a lot we don't know about sarcoidosis, but the one thing we do know is that it is a disease of the immune system. It is a disease that, for any number of reasons, and I'm sure we're going to dive into that a little bit here in a minute, but for any number of reasons, the immune system is dysregulated. It's not doing what it's supposed to do. And in some cases, that means it's being hyper responsive. We think of, immune disorders as something like HIV, where your immune system just doesn't work, and you're immune compromised and you can't fight off things. Well, there's a whole nother group of things, autoinflammatory and autoimmune diseases, certainly which sarcoidosis falls in that group, that the immune system is sometimes, like I said, hyper responsive and behaving in ways that might be advantageous in some circumstances, but in this case, not.
Right. And so you're looking for, is it a genetic
Why that is?
component?
Yeah.
Or so what is it you're
we're
trying to
trying to
figure
find
out?
out why that is. So again, a few things that we do know about sarcoidosis. Not only is it a disease of the immune system that's malfunctioning, but we also know there's a genetic component, because we see a higher incidence of sarcoidosis among family members. Now, that does not mean that because you have a family member that has sarcoidosis, you will absolutely get sarcoidosis. But what we also see are clustering of these other disorders, like what I mentioned, these autoinflammatory, like psoriasis. So another thing that I talk to the patients that come through OMRF is, do you have any other autoinflammatory or autoimmune diseases in your family? Celiac, psoriasis, lupus, rheumatoid arthritis. And inevitably, those things do tend to cluster in families. And certainly we see, like I said, a much higher incidence of sarcoidosis when you compare, like, siblings, for example, to just the general population. So we know genes are involved. So that's a big part of what we do. We're looking at what are those genes that sort of underlie why the immune system is behaving the way it does, but also looking at specific environmental influences. And I always say that from my perspective, it's not as important to identify a environmental trigger, because there's likely thousands, but rather to figure out, once you come in contact with one of these environmental triggers, whether it's pet dander, tree pollen, exposure to burn pits if you're in the military, we see higher incidence in firefighters, et cetera. But once you come in contact with that thing, whatever that thing is, what is it that's happening in the immune system? Something is being turned on. And so we want to look at what that is. So what is it about your genes that sort of give you that baseline, ready to jump into action, so to speak? And then what is it that happens once you are exposed to that trigger?
Uh-huh. Are you making any progress?
Yeah, absolutely we are. So some of the publications that we've had out most recently, we were able to using new technology, we're actually able to look at what genes are doing within an individual cell. So in the past, we would be able to say, oh, here are how the genes are behaving, in the blood. We could maybe even say a little bit about how genes were behaving in the lung, for example. But now we can actually drill down to the cellular level. So what we've reported on is getting much closer to where that immune system is going haywire by saying these specific cells are the ones who are the bad players, if you will, right? So
Hmm.
in the immune system, people talk about it like an army, and you've got the foot soldiers, and you've got the folks that are sort of coming in to do the cleanup at the end, and so forth. And so by identifying, it's actually the cleanup crew that's not doing their job, we can better then tailor the treatments to focus, because as most sarcoidosis patients know, sometimes the treatments, the side effects are just as icky as the symptoms themselves, right? So we don't want to over-treat patients. And I think that if you ask most anybody in the sarcoidosis field, they would say that that's what grieves us the most, is that we're sort of spraying people down with a fire extinguisher when all we really need is a little cup of water, and but that's all we have, right? So we're trying to narrow that focus, and then that's what some of our most exciting work has done. The other area that I find super exciting and what we're focused on is understanding why patients are so different. We know that there are patients who, and we see them in our clinic, that almost didn't even know they had sarcoidosis. It was almost just a coincident finding. They were in a car wreck and they had a chest x-ray, and doctors, oh my goodness, what's going on? You're lighting up like a Christmas tree, and like, I felt fine, and then we have other patients who are in the ICU with, organ failure. So why the disparities there? And so again, that's where we're drilling down to, even at the cellular level, to say, these people that are, doing much better, they have a profile that looks like this. And so we're actually doing, we have a provisional patent pending on a set of biomarkers that would be used as a prognostic for patients, so that we could, and this is still all very much in the works. These are long processes, right? But that we could do a simple blood test on patients and say, you know what, you're somebody we might want to be more aggressive with your treatment. We're going to use that fire extinguisher just real quick up front, to make sure we don't leave any smoldering ashes. But for other patients, based on this biomarker panel, we can say, you know what? We're not going to use the fire extinguisher with you. We're not going to be aggressive. We're going to watch you. We're going to pay attention to any new organ involvement and all the things that we would want to do anyway. But based on this biomarker panel, you're not somebody that we would predict is going to progress to, really aggressive or, life-threatening disease.
So that biomarker would be an indicator. It wouldn't necessarily be
Exactly.
conclusive, but it would be
Exactly.
one more little piece of evidence that doctors could use.
Absolutely. Yes. Yes.
Uh-huh.
Yeah. And
So
and much more informative than kind of what we have now, which is really just your sex and maybe a little bit of your ancestry, but those are the things we're teasing out.
yeah. So you said that you sit down with patients and you will ask them, well, do you recall some sort of experience prior to the emergence of sarcoidosis?
Yeah,
Like,
absolutely.
so were you in a fire, like the things that come to mind quickly, of course, we use 9/11 as
Hmm. Yes.
a case study, as it
Yes.
were. So a lot of firefighters, a lot of people who inhaled the dust, then ultimately wound up getting sarcoidosis. So you
Right.
look for a cause and effect there. And so you
Hmm.
go to somebody and say, well, was there some traumatic experience in your life
Sure.
that then 2 months later, all of a sudden you have these symptoms and it turned out to be sarcoidosis? Have you
Right.
have you found that there's a cause and effect? there?
Again, we can't really say that it's a definitive cause and effect, but I can say anecdotally,
Yeah,
I
patterns.
hear,
Are you seeing
yeah,
patterns?
absolutely. Yeah, you bet. So you can imagine in Oklahoma, and we actually see a lot of patients from rural Arkansas, rural Oklahoma, parts of Kansas that come to us. There's a lot of exposure to environmental elements, I'll say, just to kind of be a little bit inclusive. So people who say, yeah, I was raised on a farm, or I used to, mow for a 40-acre plot, twice a week, those kinds of things. And of course, nobody ever used any kind of masks or anything like that because you just didn't think about it, right? So we also have in parts of Arkansas, there's quite a bit of excavation for rock material, so mining, if you will, like rock mining. And
Mm-hmm.
so, again, lots of
Lots of
exposure
dust.
to this dust. Yes, yes. And again, not wearing masks. We see that. The other thing that I have seen as a pattern is in the military, not necessarily exposed to like burn pits, which we know have been shown to be associated, but things like jet, not jet fuel necessarily, but the smoke that comes out of jets. So we
Fumes.
have a
Yeah.
huge Air Force base here. So, somebody's like, oh yeah, my desk was inside the, the jet hangar where I sat and again didn't wear any kind of, protection and just inhaled those fumes all the time. So kind of as I alluded to earlier, I don't think that it's like, oh, it is specifically this inhalant, for example, but it's just when you're inhaling a bunch of stuff, that you're not supposed to, right? In large mass quantity. So I think that's for sure a trigger. And I hear people talk about, well, I remember that, we were spending the night on the floor at my grandparents' farm, and there was a lot of mold and mildew there. And we slept there for a week. And again, I slept on the floor and didn't even think about it. And, about a month later, I started really having congestion and just the cough that wouldn't go away. And yeah, that kind of thing.
Interesting. Do you
Yeah.
see, I would assume you see more pulmonary sarcoidosis than anything else?
So it's funny that you say that. That's exactly what I was just thinking because I wanted to make the caveat that, those inhalant exposures that I was talking about are interesting. And we do see a lot of pulmonary involvement, but we have patients who have no pulmonary involvement. Who have, almost exclusively central nervous system involvement, or I can think specifically of a gentleman whose first manifestation was bone involvement. And
Hmm.
I will say, again, anecdotally, but we're working on scientific evidence to back up what I'm about to say, is particularly in men of European ancestry, those tend to be the patients that we see that have these extra pulmonary involvement as their first symptoms, bone and CNS in particular. So, we're not sure what to make of that. For a long time, we thought, for example, that the brain was completely protected, that there was, the blood-brain barrier is what we call it. And that's still globally true, but there's a lot more crosstalk, specifically between the brain and the immune system, than what we believed to be the case, even 5 years ago, certainly 10 years ago. So, as I was talking about, so maybe even these environmental triggers, in sort of a genetically predisposed person, might trigger something that happens, even if it doesn't show up in the lungs. Um, it's activating that immune system that's then turning on, signals and switches elsewhere.
Hmm. So
Yeah.
I talked to a lot of people about sarcoidosis. I've talked to a lot of
Yes.
researchers, and I'm still very much a layperson. So I try to connect the dots, and sometimes I connect dots that don't deserve to be connected. But I see one line of defense is like let's turn off the immune response. Your you're drawing the line a little further on and saying let's see if we can stop what's triggering the immune response, or if we can figure out what's
Correct.
triggering the immune response, we can get it way earlier in the process. Is that a fair
Correct.
characterization?
Yes.
Yeah.
Yes, and I mean, I'll forgive me if I'll try not to be too technical, but I can, be a little bit more specific.
Yeah.
So for example, we are seeing that in some patients, a specific immune cell called neutrophils. Um, they are, and they're part of that sort of cleanup process, like I said. So when we have infection, those foot soldiers go in, they attack the thing, and a lot of them die in the process. Okay. Um, uh, that's just part of war, right? But also, when your body is initially responding to what it thinks is an infection or an infection, you produce lots and lots of these foot soldiers. At some point, then your body's got to go in and sort of clean up all of that, right? And just walk in and say, okay, everybody, time to go home. We're good. We've got all these, the carnage, if you will, of
Right.
the immune
Right.
system. Let's clean all this up. So in some patients, those guys are the ones that we think are misbehaving, the ones that are just aren't functioning properly. They aren't doing their job. And when they don't do their job, then the message isn't sent to, hey, back off, everybody go home. We don't need any more people showing up at the battlefield.
Okay.
But that's not the case in all patients. So that's what I'm saying about, instead of just saying, let's just suppress the immune system in general, I'm saying, no, let's identify those patients where, we've got too many foot soldiers, or we've got, the cleanup crew isn't, and let's target the treatments to those people. I think every sarcoidosis patient listening to this podcast would probably say, I don't understand why treatment X worked great for my friend, or my doctor said it's worked great for, half the, and I'm sure the clinicians would say, I mean, I know they will say the same thing. It works, these things work great on most of my patients, but I have these other patients, it just doesn't. And why is that? And so that's what we're trying to get at, because I think we're and not just us, but other people in the field are showing more and more every day that this heterogeneity in sarcoidosis patients is where we can get the most gain, because it's getting at what we call personalized medicine. It's saying, I'm going to treat you as you, not you as the check boxes of your demographic or exposures or whatever.
Well, and that's so true in sarcoidosis. I mean, it doesn't matter who I talk to or where their physicians are or what medical center they work with. You start out with prednisone, you knock it back, and then you go to methotrexate, or and there's a list. And it
Right,
doesn't matter if it's like, for me, it's neuro. For somebody else, it's pulmonary. Doesn't seem to
right.
matter where it is in your body. You
Yeah,
use the same menu of drugs and you see, but again, some people react positively and some people don't. And you just
right.
kind of go through that list until,
Yeah,
and most everything is off label. So
yeah,
insurance doesn't want to pay for it.
right.
So, Remicade,
Yeah,
you know,
yeah.
um,
It's true.
so
I was just a part of a continuing medical education conference that I spoke at the University of Texas, Houston. And it was such a wonderful time to just get with other clinical providers and people who are interested in research in sarcoidosis. But that was sort of what we were all lamenting over dinner the night before, is that we you find something that you think might work, and then the insurance company says, well, we're not going to pay for that, but we'll pay for this. And so you try that, but then you're working with dosing, and again, sometimes you get lucky and it works. And I'm not, I don't want to give a misleading message that I think, in the next 5 years, we're going to be able to say, oh, this one drug will work on you. But what I do feel very strongly within the next year and a half, 2 years, that we'll be able to provide is allow clinicians a more educated guide, if you will, right? So I often equate it to, when I take my car into the shop, Nowadays, they look at the computer, it spits out, okay, here's the error code we're flashing. But even with that one error code, they still have to go back to table in the book that they were given for that particular, car type and say, okay, this is our course of action. But because I have that error code, I'm not starting at ground zero. I'm not starting with a 500-page booklet. I'm starting with a couple of pages of options, right? So that's what I'm trying to do is I'm trying to give clinicians who are providing continuing care just 2 pages instead of a 500-page manual, and to say, because of this person's sort of molecular profile, these biomarkers, this is where you want to start with them. This is their error code.
Right. So, and can you find, so you've got this correlation and causation thing that you're fighting,
Sure.
right? So,
Yeah.
so somebody was raised on a farm. So both I and my sister, say, might have some sort of inflammatory disorder. It might be because of our parents, or it might be because we both grew up on the farm.
Right.
And
Yeah.
how do you ever split that hair?
So I think, again, that's why it's so important to look at the molecular level.
Yeah.
So we can, if I can tell you what, if I can say to you, having an overabundance of proteins X, Y, and Z in your blood
Yep.
will lead to an inflammatory response that starts, initiates granuloma formation. That's cause, right?
Right.
So then the question is, okay, well, what caused that? And so, and that's the point where we can say, well, you had this, we can look at your genetic background and sure enough, you have a mutation in a gene that leads to downstream, production of protein X, right? So that's a part of it, but there's no real genetic mutation that leads to a different expression of protein Y. But protein Y, if you're exposed to environmental, you see what I'm saying? So it's going to be what we call a multifactorial disease. It's going to take more than one hit. So, and that's why we talk a lot about the environmental exposure that happens in a genetically predisposed person. So it really is, what was that old cholesterol commercial? I can't remember, but you can thank your Aunt Sally and the donuts you had or whatever. I think it was a cholesterol commercial.
Okay.
But it's the same thing. So it's kind of like, yeah, this is my ancestry. This is my genetic background. But if I hadn't spent all that time, doing, being exposed to whatever, perhaps that wouldn't have happened. But again, you can't say that either, because maybe it would have been something else later, because you had a mountain house and or you had a beach house in Carolina. And so we're inhaling lots of mold or fungus spores. I mean, we know there's an association with that. So I caution patients with that, because I don't want anyone to ever be like, well, if I hadn't been raised on a farm, because there's lots of great things that you probably learned while being raised on a farm, or if I hadn't been in the military. No, thank you for your service. I appreciate, all you did. Because you can't play the what if game. Because like I said, you could have said, I'm not going to go in the military. I'm going to have a beach house, and the same thing happened. So
wait a minute, I have to stop you, because I don't have a beach house in North Carolina, but I have stayed at a beach house for a week every summer in North Carolina.
Yeah.
Are you telling me that there is something on the North Carolina shore that you see shows up, or is that just something you just pulled out of the air?
No. That's we know that fungal exposure. So I've seen, I can't remember who put this out. You've probably had them on your podcast, but they always show, it may have been Dan Culver, I can't remember, but they always show this really nice map of the United States, and then overlaid on that is instances of sarcoidosis. Part of it's because of demographics and the people groups that we know are most affected, but there's this funny little area that spans like Georgia, Florida, the coastline there, North, South Carolina, and so forth. And yeah, there have been studies that have shown. I mean, obviously, there's higher levels of mold and mildew because it's a much moister climate, but fungal exposure for sure is something else that we know can be an environmental trigger.
And so coastal Carolina is in that group?
Mm-hmm. Yeah. We
Wow. No,
had,
I didn't. I had never heard that.
yeah. Well, the folks at MUSC, Dr. Ennis James runs
Yep.
an
Yep.
amazing Sarc clinic there.
Yep.
Yeah, so he and I have we collaborate together on things, and we've had that conversation many times, about what. And again, it's super hard to completely disentangle all the various things that could be going on. But yeah, there have been studies that have implicated fungal. And in fact, in some mouse models of sarcoidosis, that's what they do to initiate granuloma formation is expose them to fungus.
They take them to the beach.
Yeah, no,
Look at
right?
all you mice. You get to go
I
to the
want to
beach for a day.
volunteer for that. Yeah,
No
I'll take
kidding.
yeah.
No kidding. Well, all right. Now, I have had so many patients on the podcast who are endurance athletes of one
Mm-hmm.
kind or another.
Yeah. Interesting.
And so fitness, I don't think fitness might be the trigger, but
Right.
pushing yourself beyond boundaries is a common theme for these. They're like even using myself as an example, marathon runners, people who
Mhm.
are used to pushing themselves past what the average citizen might do,
Right.
and doing it over and over and over and over and over.
Sure.
Any causation, correlation, anything there I mean, it just comes up maybe it's just the people who listen to me on the podcast because I talk about it,
Right. Yeah,
right?
maybe, but yeah.
Am
It's
I nuts?
well, the one thing I will say, it's a whole can of worms there. But I will say that we know that the immune systems of elite athletes are different than that of, normal folk. So the only thing that I would be willing to say on camera
Uh-huh.
about that, no, seriously, is that what we think could be happening in sarcoidosis, kind of going full circle to the very first question that you asked me about the immune system, is perhaps the immune system of the people that get sarcoidosis and other autoimmune diseases or autoinflammatory diseases is they are fine-tuned machines. But they're fine-tuned machines for certain circumstances, right? Where you are being exposed to lots of infectious agents, environmental exposures, etc. So perhaps when we take those people and we put them in a much more sterile, we're not living outside, we got purified air, purified water, hand sanitizer, all the things that their immune systems are just raring to go. And so the first little thing that may not be truly a threat to the system that shows up, they overreact. It's a pervasive, we call it the hygiene hypothesis, and it's been around for a long time in the space of autoimmune and autoinflammatory diseases. And people do kind of, coffee talk about perhaps, that could be the case because we do see that in other autoimmune and auto-inflammatory diseases, not just sarcoidosis.
And I would
MS
argue,
is one of those examples. Yeah.
okay, I would argue that, and who am I to argue with you? But but I would argue that the people that I know who sort of live in that space
Mhm.
push their bodies beyond the limits to where they may have weakened their immune system, right? But because their mantra is, I'm going to do this come hell or high water, even if
Right.
I'm crawling on my hands and knees by the time I complete XYZ
Sure.
event or training. So I may be dehydrated. I may have pushed my immune system beyond its limits. So I may have created a vulnerability
Sure.
that, even though I'm stronger than the guy next to me at work at this particular moment because I decided to go out and run 100 miles this weekend or some crazy
Right.
thing,
Right.
my everything is weakened and I'm completely dehydrated, and drinking water for a week isn't going to get my cellular system back where it needs it. And during that time, you're vulnerable. Is
Absolutely. Oh, 110%. So, it's probably like this self-fulfilling prophecy, right? So you've got somebody who feels good, all the time, so decides to become,
Mhm.
an ultra marathoner, right? Because
Right.
people who just kind of feel crummy aren't going to do that, right? So you've got somebody that's sort of at that peak, like I was describing, but then they do all these things to their body, 110%. And I work with in sort of another part of my life, I work with researchers in aging and metabolism. And so we talk all the time about the vital importance of sleep, nutrition, and movement. You got to move, but you don't kill yourself. You've got to eat right, give your body the right nutrients, and you've got to sleep. And that's critical to everything that we do. I mean, diabetes, heart disease, cancer, sarcoidosis, you name it.
Yeah. Yeah. All right. So let's get back to where you are. So you're working on this, you're making progress. What do you think, if you project out 10 years from now, we might know, we might be able to do, we might be able to fix based upon the research that you're doing, and other people? I know you guys all collaborate, but let's just, since
Yeah,
we're talking
absolutely.
to you, we'll talk about your research. 10 years from now, how will things be better, potentially?
Yeah, so circling back to, the biomarker panel that I mentioned earlier, I would be able to retire with a big smile on my face if clinicians had in their back pocket a test that would allow them to determine on day one that they see a patient. This is the bin that I think you're going to fall in. Um, and this is our agreed upon treatment plan based on that. Um, and right now we're looking at, I'm going to use sort of research words, specificity and sensitivity, which means that these tests are specific to sarcoidosis, and they are really good predictors. We're looking at things in like the 70 and 80 percentile right now. The tests that we perform, most of them are kind of like a coin flip, right? So this kind of a biomarker panel that we're working towards would be a huge win for patients. And we're working on the same thing in the diagnostic space. It's just not quite as far along, partly, like I said, because of the heterogeneity of sarcoidosis patients. But we would love it if somebody didn't have to have a lung biopsy, right? If they could actually be diagnosed accurately without an invasive procedure. So those are two very active areas. But the other areas, like I said, I think that we are really making headway in identifying specific molecular targets. So, not having to say we're going to suppress the entire immune system, but rather we're going to focus on this subset of immune cells. And even more specifically, we're going to target this set of genes that are being turned on. And I don't mean gene therapy, but rather we have, there's drugs on the market that can tell a gene to just chill for a minute. Not turning them off, like I said, not having to do gene therapy, but just decreasing their activity. And I think all of that is moving towards this personalized medicine goal, which would make me super happy and
Yeah,
lots of
really,
patients, I think.
really. So do you think, is there any such thing in your research as an aha moment where all of a sudden everything comes together and a light bulb goes off and we're like, oh,
Yeah.
that.
Yeah, yeah. There's a whole lot of well, that didn't really show anything, but there are definitely those aha moments. And like I said, we're kind of right at that place right now. We're getting close to publishing some work specific to the differences in what we see by ancestry, people of African ancestry versus European ancestry, and specific to people that have what we call a high disease burden, which means if you ask a patient, Monday, Wednesday, and Friday, how they feel, how their disease affects their everyday life, plus, some actual clinical metrics attached to that. If they're like, it absolutely affects me, in every aspect of my life. And we've developed kind of a new metric for defining that. And those people that have high disease burden, what does that look like at the molecular level versus what low disease burden looks like? And again, I think those are going to be huge wins for the community, both on the clinical side as well as the patient side.
So do we look for, say, a paper in the next 12 months or a poster
Yeah,
or something?
absolutely. Oh, yeah,
Tell
absolutely.
us what we can expect.
So we actually have a couple of papers in the works. One is, as I just described, kind of looking at the immune cell profile of sarcoidosis patients and divvying those up. I'll divert for just 1 second, but I don't know if folks are aware, some of you probably are, but there is one sort of biomarker that is agreed on by pretty much everybody in sarcoidosis. If you have a specific, it's called HLA DRB1 0301. And if you have that allele, then you are, this has been published on for decades by multiple folks. And if you have that particular allele, we can almost guarantee that your sarcoidosis is going to self-resolve, maybe even without treatment at all. So we have taken a subset of those patients and we are profiling their immune systems, like I said, down to the cellular level and saying what's different about those folks versus all the rest of these sarcoidosis patients. And that's a part of the paper we're about to put out. And then we're holding those profiles up and saying, okay, what if you are, a sarcoidosis patient of European ancestry, which group do you look more like? And if you're a sarcoidosis patient of African ancestry, which group do you look more like? Or are there other nuances? And that's the paper that we're about to send out that I think will be really helpful in sort of categorizing sarcoidosis, while it's one disease, as having lots of subtypes.
So the paper won't answer all those questions. It will say this is the next area of study that we need to go into.
Exactly. But I do think that it will point to saying, we're going to say that. So because this group of patients looks like this, these are the types of treatment that would work better for them because they're targeting T cells, for example, or, this specific treatment would work better in this group of patients because they're targeting, monocytes, which is another kind of immune cell. So we will be able to sort of describe that and say in this group of patients, it's actually, the T cells are being just fine, but it's, this other group of cells that are over responding and so forth. And so that's in this group of patients, that's what we should be targeting, not this other thing.
Interesting. And why did you choose sarcoidosis among all the things that you could study?
So good question. Somewhat serendipitously, I, as a very early right after I graduated from undergraduate, I worked on a genetic study in lupus. So that's where I sort of fell in love with research and just the idea of doing, academic medicine and so forth. But then I trained at Case Western, which is in Cleveland. And during my time as a graduate student and in medical school at Case Western, I got introduced to sarcoidosis. Someone there was working on it. I hadn't even met Dan Culver at that point. But then once I graduated, kind of remained involved in both the lupus study and the sarcoidosis study. So knew I loved this idea of the immune system and understanding more about the immune system and autoinflammatory diseases. And then so once I got out on my own, I had the opportunity to apply for funding, and I just saw the need in sarcoidosis. Had at this point been exposed to the patients because I was working at both Case and the Cleveland Clinic, and just really had a heart for those patients. And so there we go. That's where, and my mother actually, who has passed, was the sufferer of an autoinflammatory and autoimmune disease. So that, again, that space had a personal connection for me as well. So yeah, it just sort of happened, and I'm so glad it did.
Yeah. Well, we're glad you're on our team. Thank you. Very much
Absolutely.
appreciated. Any last thoughts you want to share with me?
No, I mean, thank you for what you do. I'm thankful to the FSR. I've been, privileged to be a part of their steering committee and their leadership teams for, a couple of years now. And it's just an amazing group of people who are truly dedicated to a group of patients that have been wonderful. I mean, the folks that we see are super energetic and inspiring. And I guess my final plug, gratuitous as it may be, is please get involved in research if you haven't, because like we've talked about all along, sarcoidosis is such a heterogeneous disease. The more people like you, whoever you are, whatever you means, that participate in research, the better we can develop, the more quickly we can develop medicines and treatment plans that are personalized for each patient. So that's my little commercial. But
Okay. All right. So somebody's listening to this and they want to participate. I mean, do they need to? They can't go to Oklahoma and give blood. So how do they or do this? Is that what they
yeah,
have to do?
actually, so we do have mechanisms in place where people can participate in our project even from afar. And we will soon be sort of opening recruitment centers through collaborations in the state of New York, collaborations in the state of South Carolina. But we also have ways that people can participate and send their blood samples to us. We've had participants from Louisiana, from New York, from obviously Texas, Arkansas, Missouri, Kansas, all the surrounding states. And we will work with you to do our best to get you involved.
Okay, very good. Well, I'll put a link to your organization in the description,
Perfect.
show notes, and if people want to pursue that, then they can do that.
Excellent. I
All right.
appreciate that.
All right, Dr. Alexander, thank you so much. I appreciate it.
All right. Thank you so much.
Montgomery, I'm
Bye.
so sorry I said that.
Oh, you're fine. You're fine.
But yes, but thank you so much. I really do appreciate it.
You bet. All right. Bye-bye.
Bye.
I feel like a zombie, just feeding and stumbling.
So thanks to Dr. Montgomery for taking time from her bungee jumping and her research and her ice skating and her singing to take the time and to talk with me here on the FSR Sarc Fighter Podcast. I want to let you know this is a good time to contact me if you'd like to share your story on the podcast. The best thing to do is email me at carlinagency@gmail.com. The official Sarc Fighter song, called Zombie, is by Mark Steyer, who plays in a band called the White Hot Lizards in Alberta, Canada. You can hear an update on what's going on with Mark. He's a fellow Sarc Fighter back in episode 118. The Sarc Fighter Podcast comes out every other Monday. As I'm speaking today, neither my trusty boxer Dougal nor my lovely youngest dog Shandy are in my office. Because why? Because my wife is home and she's working in her downstairs office, and yes, they are cheating on me once again. They only want to hang out with me when mom's not home. Man, I can't tell you how much I hate that. The backstory to the founding of the Foundation for Sarcoidosis Research is episode 11 with Andrea and Redding Wilson. You can follow the Sarc Fighter on social media, Facebook, Instagram. I'm even on Peloton as Sarc Fighter. My cycling blog, Carlin the Cyclist, has a section called Cycling with Sarcoidosis. If you're new here and you're just trying to figure out what Sarc is, go back and listen to episode 2 with Dr. Simon Hart. My story is episode 1. Again, you can send me an email at any time, carlinagency@gmail.com. Until next time, keep fighting.
Learn to suffer, you feel pain someday. fade away. Dead man walking, trying to keep up the pace. Dead